Thanks, Chrissy, and delighted to be here and present what we've been discussing in the Neurology Workgroup. I will say I'm learning so much, originally from Chrissy herself, now extending to Radha, Rachel, many others who are here in this room, and with many of my trusted colleagues in the adrenal leukodystrophy world and neurologists here, and that tells me that at least half of that equation of inventory we have fulfilled, which is we have the right people in the room. I think the other part of inventory is just sort of getting a really good sense of the lay of the land, what is the neurological phenotype of patients with adult refsum, and I think that is, we're at an exciting beginning, but we're at a beginning. And just to point out that this work group, many people contributed to who are here, and Amina Smith-Fine, of course, somebody who's already in the ALD field and other leukodystrophies, contributed so much to understanding wearables, gait, and balance, so I think that's been such a key contributor. Radha, obviously, teaching me so much about metabolism and how it's impacting neurological function, us discussing how much is acute versus chronic of neurological presentation. We had Reza Sejadi, our neuromuscular expert at MGH, talk to us about peripheral nerve findings, the distal length-dependent neuropathy that shows up in adult Refsum disease. Robert Thompson, our genetics and metabolism fellow, who is really enthusiastic about continuing even throughout now his genetics and metabolism fellowship to think and work with Joe also about gene editing. And Carolina, I know that even your patients are pulling you in here and connecting us by email. So I will probably start off by saying and pointing to the gorilla in the room, which is we're here at the United Leukodystrophy Foundation, but I think of all of the diseases we see here, adult refsum is probably the least of a leukodystrophy, okay? The white matter lesions in brain, while they might be present, they don't seem to be the aspect that is impairing day-to-day neurologic function. It is rather sort of the peripheral vision, the vision loss that is, I think, of much greater importance, as well as the most distal parts of our nervous system, but many things in between, luckily, and Christy is such a testimony to the high cognitive executive function. Those things seem to be working quite well. Recognizing that, our neurology work group is really tasked to identify disease burden and unmet need here, which is largely in the realm of the combined vision and balance and gait difficulties, and also pain realm. And so I think what we've been discussing on our work group is, in large part, trying to assemble the phenotype of neurology, which is different from classical adult leukodystrophy patients. And so I state that negative so that we are open to new disease concepts and new ways of thinking about this, because I think sometimes one can go in one direction and spend a lot of time getting granular and missing the point. And so I think collectively us trying to learn and listen to the patients to get some of those boundaries and that framework right is key. So I think the central question really for our work group has been, what does meaningful neurological improvement look like in adult Refsum disease? And the questions we've been pondering is, how does the disease progress? And part of this sense of progression is this dependent on a distal length-dependent axonopathy, similar like what we might see in a diabetic polyneuropathy, and there certainly are many genetic inherited neuropathies that we can learn from? Or is it something else? And how much is vision and vision loss playing into this? And how much might other compartments of the nervous system or the musculoskeletal system be playing into this? And so I'm really actively trying to create inventory here, because beyond the peripheral neuropathy, as Christy has also taught me, there are aspects of tendon and bone that are all playing into also pain symptoms, and paying attention to those aspects is as important to daily functioning and neurologic functioning day to day as anything else. Connected to that is the question, what is reversible, right? So clearly if you're born with a bone abnormality, that's not necessarily reversible, but there are aspects of your performance day to day in neurology that is very much fluctuating and able to improve over time. And as we were discussing about exercise function, I was very much reminded how much we use that in other disorders to assess the level of improvement that could be gained, whereas here you might be thinking about it as a stress test in terms of fasting or lipid stimulation. What outcomes matter most to patients? So this is clearly linked to also the last one, which is how should we measure meaningful improvement? And a lot of this is ultimately linked to how would we design trials, why would we conduct trials to achieve what meaningful change? So just because we measure it, and that's been a theme that we've talked about also in, you heard it so nicely from Rachel in the vision group, it doesn't mean that it's meaningful. You can measure it, but what is that threshold that is a meaningful change for patients, and what numbers of patients and what duration of time should we be looking at in order to achieve a meaningful change? So if a therapy reduced Phytanic acid tomorrow, would patients walk better, fall less, feel less fatigued, remain independent longer? Today we cannot confidently answer these questions. I think even after today, my questions, if anything, have gotten larger. I would sort of step back and say, beyond Phytanic acids, what is the inventory of variants out there? And how many PHYH variants are there? And what are the levels of Phytanic acid and disease burden associated with it? When I learned now from Radha that there might be patients picked up with RP who have normal Phytanic acid levels, I want to understand what are those variants, and knowing right now what a revolution we're going through in neurogenetics, where variant classification is becoming tantamount, and we're learning about this in other adult diseases such as ALSP and Carolina and Wolfgang and others, and Mark are here who see so many adults, where we understand that these differences in variants can make a huge difference in terms of metabolism, but also clinical presentation. But I want to acknowledge at the same time, we have a handle on biochemistry. We shouldn't lose sight of that, and the Phytanic acid is a huge contributor here. But each individual patient that we encounter, even those that might not fit the bill, and where there might be dissociation between the PHYH variants, the biochemistry, and the clinical symptomatology, could teach us something. And it's often those exceptions that can teach us quite a lot. So walk better, fall less, feel less fatigued, remain independent longer. This is coming in large part out of also a nice survey conducted by Diane on pointing to the things that patients really care about. And I think something even like fatigue is something we hear as neurologists, but we don't have a good way to quantify. And these are things that really are meaningful to patients, but at the same time are difficult to include as measurable outcomes in trials. So this is something that we need to actively think about moving forward. So I just want to point out just briefly that these questions that I raised initially are actually the same questions that we would ask as we are going to design therapeutic trials, right? So timing, reversibility, and meaningful, measurable items. Why measure neurologic improvement, and why is this difficult with adult Refsum disease? I think I alluded to this before. Neurologic disability arises from interacting systems rather than a single neurologic deficit. If you have vision loss, then your peripheral neuropathy and the associated ataxia might not just be dependent on your peripheral nerve or your sensory system sending signals on joint position in space, but might be impacted by peripheral vision as well. I'm also very much intrigued by aspects of pain, bone abnormalities, tendon abnormalities that might be restricting motion, and those are also contributing to gait and balance. And so this is more multifactorial than a pure nervous system disease alone. I put this graph in here from the beautiful paper that Radha spearheaded, which I think has really helped us put a stake in the ground in terms of diagnosis, metabolic management of adult Refsum disease. And just to highlight here that the most prevalent symptoms and their frequency that they're seeing in guys in St. Thomas are around RP and followed by difficulties in smell, and the neurologic symptoms really cluster below here, from neuropathy to deafness, ataxia. But note here that we're talking decades here. None of us can conduct a trial that is going to last a decade. And so if there are changes here that are only significant over a decade, that is not feasible for a trial design. That's why we need to go in and find, with the help of Amina, measurable day-to-day items that can tell us in a shorter amount of time whether improvements are possible, so that we don't have to conduct trials that are going to last years to understand whether a meaningful change would be possible. So before we can develop future therapies, we must define meaningful neurologic improvement. If a therapy existed tomorrow, could we prove that it worked? Right now, the answer is no for most of these clinically meaningful endpoints remain undefined. Adult Refsum disease specific patient-reported outcomes are not available. Reversibility uncertain, biomarkers unvalidated, natural history incomplete. Instead of seeing this as a glass half empty, I'm going to say this is a glass half full, meaning we have a lot to gain if we step in here and conduct one short, meaningful, longitudinal study together. The primary neurologic barrier to therapeutic development is not a lack of potential therapies, it is a lack of validated measures of meaningful neurologic improvement. To solve this gap, we need longitudinal natural history studies, ARD-specific patient-reported outcomes, objective functional outcome measures. I think working with Radha, we've already established a nice framework of a REDCap database where we will jointly align and collect data from the patients we see. But I think beyond that, a Delphi process to establish consensus on neurologic endpoints, and also understanding who we need to inform this. And here I'm looking to Rachel. We definitely need our ophthalmology colleagues. We probably need people who are also slightly peripheral to neurology, maybe in physiatry, people who are thinking about pain symptoms and maybe even, where appropriate, orthopedic issues. I think there's really room for innovation and originality by thinking a little outside of the box to really fit this with the patient population and the needs that they are experiencing. So the opportunity within 5 years, we can transform neurologic assessment in ARD from largely descriptive observations to trial-ready outcome measurement. I want to give Diane full credit for so succinctly and beautifully putting this here on paper. The opportunity is here to create a longitudinal natural history, think about patient-reported outcomes, with Christy and the engagement of the community, I'm confident we can bring that together. Gait and balance measures, wearables with the help of Amina Vision neurology integration, as Rachel already so nicely mentioned before, a chance here to work together. I think in the biomarker field, obviously, with Anne and Suzanne and others here chiming in, what can we learn from nutrition and things that Masumi talked about? Are there new biomarkers we can look at? But we need a consensus building process to understand what neurologic endpoints can be captured and what fits the patient population that we're seeing. Strategic priority number 1, define meaningful neurologic improvement. Define what meaningful neurologic improvement looks like across the spectrum of adult refsum disease, knowing well that this spectrum is changing, expanding as we get to know new patients, as we're seeing new patients, as patients are being now diagnosed by new methods. Do we really understand the full spectrum of what this disease looks like? But let's at least start by building to fit the population we know. If we're starting to build something that doesn't really fit the population, then we're amiss. So natural history, patient-centered outcomes, disease progression, phenotypic variability, a lot of that, I think, in the REDCap database that Radha has already nicely designed with our group is going to work. So a natural history-informed framework for meaningful neurologic improvement. The other piece is really, I think, coming and will be low-hanging fruit in a consensus process where we can decide on neurologic endpoints and understand what can be measured is meaningful and consistent and can be reproduced. So many of the things here that I've spoken about before, but I want to open this up a little bit for discussion because I think we have so many bright minds here in the room, and discussion and conversation about this is key. Thank you.